I should briefly say that I'm a hemato-oncologist and transplant physician in Birmingham in the center of England. I chair the UK AML study group, and I'm passionately convinced of the importance of clinical trials in accessing new therapies for patients and moving forward in significant size steps outcomes for patients with AML. And I think Gail and Ralph will be touching on the progress that has been made. Now over to you, Gail.
Hi, Charlie. Thank you. Hi, everyone. My name is Gail Roboz. I'm a professor of medicine and director of the leukemia program at Weill Cornell Medicine and the New York Presbyterian Hospital in New York City. Very excited to be on this webinar with a good friend. So Charlie and I both are friends, opera lovers, and we love to argue and discuss things about AML. So that's extra fun for me. And it is my extra super great pleasure to introduce Ralph Hills, who is, wait for it, a real live patient. And obviously what he says is much more important than what Charlie and I will come up with. But actually, we're going to try to have a very synergistic and interactive discussion so that we learn a little bit of AML, learn a little bit about Ralph's experience, and learn how to advise all of you in this journey. And Ralph, please go ahead and tell your story.
Thanks, Dr. Roboz. I am pleased to be joining you and Dr. Craddock today. Hello, everyone. I live in Connecticut, about 50 miles from New York City. I know I am still here today because I had an alert oncologist who did a leukemia mutation test on me. December 2014 was a life-changing month for me and my family. I had a routine blood test for minor surgery, and the next day, the doctor's office called and told me to immediately go to our local cancer center. Then my wife and I went to that and met a stranger called an oncologist. It was a rough day. He told us 4 things. I had a serious and advanced blood cancer called acute myeloid leukemia, AML. He prescribed 30 to 60 days of treatments called chemotherapy. When I asked if it was serious, he said, "Mr. Hills, go home and get your affairs in order." And the 4th thing he said was pretty important. He said, "Go to New York City and get a second opinion." For the next 2 months, I was in a mental fog, just trying to deal with how our lives had changed forever. But I did learn that acute is a bad cancer word because it means fast growing. Chemotherapy was a decades-old standard of care for AML. It has harsh side effects and is only a treatment, rarely a cure at my age. And I interpreted getting your affairs in order as a polite phrase that my life expectancy had become shorter. I now more than ever appreciate the doctor's 4th comment recommending we seek a second opinion in a larger facility in New York City. We went to New York and met our new oncologist, our Dr. Roboz here today, who did immediate blood and bone marrow extractions. But I was concerned she also prescribed a long schedule of chemotherapy, the same plan as in Connecticut. So 2 weeks later, I scheduled my chemo treatment starting on a Monday morning. But that Sunday evening, 12 hours before that, Dr. Roboz called us at home and asked if I would consider changing my treatment plan. Unknown to me, Dr. Roboz had ordered special new tests, which disclosed I had a leukemia mutation that might respond to a new non-chemotherapy treatment. So my family and I, while on the phone with Dr. Roboz, now had the choice between an unknown new drug or traditional chemo with its harsh side effects and probable less than 1 year life expectancy. Dr. Roboz told it was our choice. But as we sat there, we all realized that Dr. Roboz must have called for a good reason. We did not hesitate, went to New York City the next morning to start what was called a clinical trial. I started on a 3-year series of 1 oral medicine. Yes, I was terribly sick, sleeping almost 24 hours a day for 5 months, barely mobile, unable to take in any food, losing 45 pounds fighting this disease. My mutated AML white blood cells, called blasts, rose to 70% of my marrow volumes. We battled the leukemia, jaundice, infections, digestive tract, and other issues. My wife Dorcas carried almost all the physical and so much of the emotional load for a year. She allowed no visitors at all except family members, screened for colds or germs. But something was keeping me alive longer than expected. Amazingly, after 5 months, the trial drug was making my bad leukemia cells disappear and leaving room for new healthy blood cells and platelets. What a thrill seeing the blast counts go down. 10 months after my trial started, I could finally eat and started the long road back to physical recovery. I finished the trial in 2019, and now I'm on a maintenance plan of about 5 days a month, chemo infusions, and a new oral drug, which are keeping me alive with good quality of life. Yes, an AML diagnosis is a changing moment for your life, for the patient, family, and friends. I feel I am very lucky. My timing was good, and Dr. Roboz did the right thing 10 years ago. So we are here today encouraging every new AML patient and doctor doing all they can to communicate well, do modern and faster mutation testing, and make good choices for the personalized best treatment they can find. Thank you very much.
Thank you, Ralph. That was a really inspiring story and a great way to start this webinar. Let me just put this into some context. I don't know how many of you read The Double Helix by Watson and Crick. It's a wonderful book about the story of discovery of DNA. Much of it intellectually came about in King's College, Cambridge. And they describe how on freezing cold winters in their set in Cambridge with the frost on the inside of the window, they came up with this concept of how DNA was structured. It was readily apparent that understanding more about DNA and how it drove clinical disease was going to, in the end, be practice changing. And so for the next 60 years, governments across the world invested trillions of dollars, pounds, euros into basic biomedical research. But even up until 10 or 15 years ago, with a few exceptions, it was very difficult to show how the amazing science that was teaching us so much about disease biology, particularly in cancer, particularly in leukemia, really was impacting patient outcomes. And it's really only in the last 10 years, as we'll discuss in the next few minutes, that it has become clear that that brilliant work started by Watson and Crick now allows us to categorize mutations that impact clinical practice. So having invested for these 60 years, the trillions of pounds of taxpayers' investment, it really is now urgent that we connect patients with these transformative benefits. So this is the A-level course slide, which shows to you that mutation is a change in the DNA sequence in a coding part of a gene, in the part of a gene that creates a protein. And as a result, it results in the DNA sequence malfunctioning and not producing protein in the correct fashion. And that drives a whole range of human disease. Next slide. So what we have been able to do in the last 20 years is to catalog in a range of cancers, but we're talking today really about one of the lead conditions, acute myeloid leukemia, where pioneering work has been done. Firstly, that particular mutations are uniquely associated with the presence of acute myeloid leukemia. So the presence of these mutations in a bone marrow or peripheral blood sample in a newly diagnosed patient with presentation akin to acute myeloid leukemia can clinch the diagnosis of AML. Secondly, it's increasingly clear that by categorizing the different mutations that occur in AML, we can identify some associated with a very good response to chemotherapy or stem cell transplant, and some equally that are associated with a poor response. So it's really helpful for patients and families because characterizing their mutations allows you to have some idea about prognosis and likely course of the disease. And then finally, and importantly, we'll be talking about this quite a lot, is increasingly as we develop agents that can target leukemic cells with specific mutations, the presence of these mutations guides the rational use of targeted therapies. So next slide, please. And as a result, it's become axiomatic that all guidelines about the diagnosis and management of AML now insist that characterization of mutations commonly occurring in acute myeloid leukemia through a technology called next generation sequencing is really now mandated in the diagnosis of AML. And then just a couple of other areas where the presence of mutations are valuable in terms of guiding treatment. So we know that transplant is a curative therapy in many adults who are fit up to the age of 70 or 75. Deciding which patients to take to transplant, given the fact that it's an onerous procedure, is a sophisticated process. And there are particular mutations that can tell us that a patient will do very well without a transplant, so they can leave that behind, or others in which transplant will really only be the only curative option. We're increasingly using the mutational analysis in sophisticated analysis called measurable residual disease, MRD, to characterize low levels of disease in patients on treatment, and that's guiding treatment making decisions. And as I said, taken together, we're able to use these mutational profiles now to empower patients to understand about their disease, about its prognosis, and about what sort of treatment they should deserve.